Good afternoon, everyone. Hi, I am Susan Beyer. I'm the Executive Director of the Allen County Public Library. Thank you for spending a glorious fall Saturday afternoon with us at the library. We're honored to have you here to talk about a topic that has such impact on families and on communities. We are grateful for Dr. Cooke's appearance. We're also grateful for the partnership of the network of the National Library of Medicine. And I would like to introduce a representative from that organization, Darlene Caskey. Darlene is the Community Engagement Coordinator for Region 6 of the network of the National Library of Medicine, located at the University of Iowa. She supports the mission of the National Library of Medicine by providing health professionals with access to biomedical information, as well as improving public access to consumer health information. She has her consumer health information specialization from the Medical Library Association, and she's earned her Master's of Library Science degree from Indiana University, Bloomington. Please welcome Darlene to the stage.
Thank you. Thank you, Susan, for that introduction, and thank you for coming today. It is our pleasure that we were able to sponsor this event for you. We hope you will enjoy it. I just wanted to say a few words about our agency. Some of you may not know who we are. And as that's a mouthful to say, the network of the National Library of Medicine, we are mostly called NNLM. We are an education outreach arm of the National Library of Medicine, or NLM, which is located in Bethesda, Maryland. And it is the world's largest biomedical library. It is also one of the 27 institutes of the National Institutes of Health, or NIH. And the National Institutes of Health is one of the largest medical research agencies in the world. They make discoveries in medicine and science so that we can improve everybody's health. And we do this because everybody deserves quality health resources. That is the mission of the National Library of Medicine. That is the mission of our network of the National Library of Medicine. And we do this by providing quality health information that's available from NLM and NNLM. One of those resources is called Medline Plus. Medline Plus is a free internet web source, and it has up-to-date information that's reliable, vetted by librarians at the National Library of Medicine, as well as the scientists at NIH. It's available both in English and Spanish, free for any browser, any device that you have with an internet connection, and it does have quality and trustworthy information free of ads. So if you were thinking about, or if you're going in for a procedure, let's say colonoscopy, you could come here, read about that procedure, and be more informed, and then talk to your provider. And that is the reason why we provide this quality of information. We want people to make informed decisions about their health and the health of their loved ones. And we couldn't do this without partnerships. That's why we're so grateful to the Allen County Public Library for hosting this program with us. Libraries don't always get the praise that they deserve. There's wonderful community organizations, such as your library here. This is a beautiful building. I have to thank especially Megan Bell, Anna Kellerman, and Susan Beyer for welcoming us. So now I would like to introduce, we have a very important guest here today, your health commissioner from Allen County Health, or from Allen County, Dr. Gutwein. He holds his bachelor's degree in biology from Indiana University and graduated from the IU School of Medicine in 1990. He's board certified in emergency medicine and is a fellow of the American College of Emergency Physicians. He is a president of the Professional Emergency Physicians, a team of emergency physicians and physician's assistants dedicated to providing quality emergency care to patients in Northeast Indiana. And Dr. Gutwein is a director of emergency medicine at Parkview Health, where he regularly appears on the website in blog posts and videos on health topics. And they range from staying safe in extreme heat and preventing dangerous fake prescriptions from taking fake prescription drugs, to seeking emergency care for chest pain or seeking safety in times of weather emergencies. So now I want to introduce Dr. Gutwein.
Thank you, thank you. That was a little much because I'm not the big guy here today. You know, we're all here to hear Dr. Cooke, not to hear Tom Gutwein. But thank you for coming out today. I want to thank the Allen County Public Libraries for putting this together today. I want to thank the NNLM for supporting this to make this happen. You know, some people, I've been asked, why is it important to have Dr. Cooke here today to talk with us? And I'm so glad that you guys are here to listen to what he has to say. It's because, you know, I've been in healthcare for 30 plus years, and as an emergency physician, I've worked in over a dozen emergency departments in the state of Indiana. Some of those see 15 patients a day in 24 hours. Some of them see 300 patients a day. And so there's a wide variety, but what I see across the state, no matter where I'm working, you know, I can go into a different ER, and when I have a new doc come in, I say, you know, you have to learn the electronic medical record system, you have to learn the nurses' names, you have to learn where the procedures are done, where the equipment is. But the thing that's always the same is the health of the patient. The health of the patient is what we see, and we see the same diseases at different locations across the state. And one thing that unfortunately we do see, no matter where you're at, is you'll see people with substance use disorder, people with HIV, people with hepatitis. We haven't seen these near as frequently today as we did 20 years ago. And that's a great thing. That's really a great thing. I thank a lot of people for making a lot of inroads into those actions. But what we need in the emergency department, when we see people that have substance use disorder, HIV or hepatitis or different problems like that, things related to drug abuse, we need resources in our community. And those resources in the community are never enough. Until we get to too many peer recovery coaches, I'm going to keep preaching the same speech. Because I think that if we had too many peer recovery coaches for our area, that would be a wonderful day, wouldn't it? That would be something that we would all rejoice. But I think that having these agencies support those people that come to the emergency department, they come to the family practice clinic, they come to all kinds of, they seek health care in a lot of different places, and some of them never seek health care. But those people are the ones that we need to plug into our resources that we have in this community. So by having Dr. Cooke here today and just talking to us a little bit about this, for those of us that have been in this for a long time, it's a refresher course, I would just say. And those people that haven't seen this a lot, and I would tell you, you know, even like there's a lot of people that I communicate with every day, like in my family, that don't see what I see in the emergency department. For those people that haven't seen this or haven't felt this, then I think Dr. Cooke can bring that to you. I think he did a wonderful job in his book of outlaying the problems and the challenges with those problems. And I don't want to take any of his thunder, but I think that he's just done a great job. And I hope that what he can bring to us today is not just a refresher course, but for the rest of us, a new course to learn about this problem that's still going on in Allen County today and across the country. So just a little bit of an introduction for Dr. Cooke. I think in 2004, he was an eager young doctor who set up shop in Austin, Indiana, in Scott County, the southernmost portion of the state. A little over a decade later, in 2015, the small town of 4,000 people would be the epicenter of the worst HIV outbreak fueled by injected drugs in the United States history. There he saw firsthand how socioeconomic and other disparities impact the health of not only individuals but entire communities. He experienced the transition from do no harm to protect from harm. Through efforts that were helping him to push for the state to lift a ban on the SSP, or the Syringe Services Program. He notes in The Canary in the Coal Mine, his book about the experience, that the whole disaster could have been prevented by proactively investing in the community and in public health. That is absolutely key to promoting and protecting the health of everyone in our community. Dr. Cooke's book and his experience offers an eye-opening look at the public health, the disease, the preparation, and the compassion. I'm happy to introduce Dr. Cooke to you today. So without further ado, Dr. Cooke, thank you.
All right, thank you for that incredible introduction, and thank you all for being here. I really appreciate it. It's a lot easier to give a talk in front of people instead of an empty auditorium, so thank you for being here. I am from New Albany, set up my practice in Scott County in 2004, like was mentioned, so I had a little bit of a drive. but I'm honored to be here. Never been to Fort Wayne before, so thanks for inviting me. And it's a lovely city. I had no idea, honestly. So you should be proud of the place that you live. We drove around a little bit as we came in, and you have a lot of resources and a lot of really great things going on here. I'd love to hear more about that, as we get into the question and answer session, and then maybe afterwards as well. So my book's title, as you know, is Canary in the Coal Mine. And what that's referring to is in Appalachia, coal miners would take canaries down into the coal mines with them. And you know why they did that. It was to warn them of toxic conditions that might exist there. And so to me, there are places all across America, like Scott County, that are showing us that there are toxic conditions within our communities. Everywhere you go in America right now, there are toxic conditions that are harming people, and we need to pay attention to that. If you knew that, going into a certain room would be harmful to you, you would avoid that room, or we would go in there and, adjust what was going on in there that was causing harm, right? We know that there are places that are harming people, and we have the opportunity to do something about that, but we need to know what those harms are and what the solutions are. And I hope to talk through that a little bit today. So Indiana, as you probably know, is known as the crossroads of America. And in 2015, we became the crossroads of multiple deadly epidemics, including the opioid crisis, adverse childhood experiences, social determinants of health, and HIV. We actually became the epicenter of the worst drug-fueled HIV outbreak in the history of the United States, out of a town of 4,300 people. Most of the people that we take care of in Scott County came out of Appalachia, and my family also migrated out of Appalachia. This is me when I was much cuter. So my family, several generations back, migrated out of Appalachia in search for better opportunity. They ended up being squatters, actually, on the Ohio River just inside of the Indiana border. They're listed, I think it's the 1920 census. My family's actually listed as squatters. My mom and her siblings grew up in absolute poverty. She describes how they would just find shelter sometimes wherever they could. If they got found out, they would have to grab all their belongings that they could carry and just scurry under the cover of night often to find new shelter. So my mom, growing up, didn't have anything more than what she could carry from one place to the other. This is my mom with me. Now, she married my dad at 16 years old. Just can't get my brain around that. 16 years old. She dropped out of high school, moved to Texas with my dad to a military base where they found structure, where they found educational resources, they found mentors, people to invest in them, things they never experienced growing up in poverty in Indiana. And it was through those mentoring relationships, through the resources that they had access to, the structure, that they were able to start finding achievement and success in life. And they were able to give my brother and me a better life than they had growing up. But not everyone in my family was so fortunate. This is my mom at her sister's grave, my Aunt Sally. She died in her 30s of a drug overdose. She dropped out at 14, never found the same structure, never found any mentors, was in and out of relationships, went from alcohol to opioids. My grandfather and her actually drank a lot together, and they found that they could go to doctors' offices and get opioids, use some themselves, but they would actually bag up some and sell them to support themselves. My grandfather and my aunt, father and daughter, were a team. They went to a yard sale and got my grandpa a walker. He didn't need it, but they got him a walker so that they could go to a doctor and get opioids from him. So that's how my Aunt Sally lived life, my grandfather as well. They both died young. My Aunt Sally, again, in her 30s, my grandfather in his 50s. I'm going to be turning 52 here in about 2 months. So it's starting to hit home a little bit that I'm about to outlive, I hope, my grandfather. So, people are losing decades of life through diseases like substance use disorder. And it's coming out of systemic harms in our communities that we can do something about. But oftentimes we just tell people that they need to try harder. Now, when I went into school, my mom dropped out at 16. My Aunt Sally at 14. My grandfather made it to the 3rd grade. My family didn't have a good history with school. Now, spoiler alert, I did make it through medical school, but early on in elementary school, I struggled. I didn't have that heritage passed down to me of good educational outcomes. But my teachers recognized something in me and said, you're a smart young kid. You need to try harder. Try harder and you'll do better. How many times have we heard that? Try harder and you'll do better, right? And I thought I was trying hard. I'd pay attention. I would try real hard on my exams, but I was getting B's and C's. Try harder. No one told me what that meant. Nobody stopped and found out my history and my heritage and what I knew, what I didn't know. So this continued on into college, and my professors would pull me aside and say, you need to try harder. I didn't know what that meant. I really didn't. And it seems ridiculous at this point in my life because, now I have kids and I'm teaching them how to do the things I didn't know how to do at the time. So in college, I started meeting students, peers, who came from a higher socioeconomic class than I did, joined their study groups, and all of a sudden I started realizing things. You can take notes during class. That's something you can do. You can outline your textbook. I learned how to actually make an outline from my textbook as I was reading and then convert those notes and those outlines into flashcards. And then I would start drilling myself with flashcards and study my outlines, study my flashcards. And all of a sudden, something unlocked in all my effort that I was really, truly putting into school. I was trying hard, but I didn't have the tools and resources to turn that effort into outcomes. But once I had those things, I started getting straight A's. And then I graduated from med school with honors. Went on to residency in Muncie, graduated there in 2004, and then set up my practice in Scott County. And you can read a lot about that early experience in my book. I hope you've read it. If you haven't, I hope you get a chance to. What I want to talk a little bit about is how, we talk a lot about substance use disorder, and we should, because it's a significant issue all across America. But sometimes it's hard to really relate to that unless you've experienced that yourself or know someone who has. But we can all relate to life expectancy. We all want to live long lives. Who wants to live less? We all want to live as long as we can, right? And we want that life to be one of health and wellness, right? We don't want to spend 10, 20 years of sickness before we die, right? We want to be really healthy until the night we go to sleep and we don't wake up the next morning, right? Yeah. So we can all relate to that, but what we need to realize is in America, something unique is occurring for the first time since the 1920s. And that's that people are living shorter lives. We have less life expectancy in America today than we did just a few years ago. This study was recently released, and it looked into this. It was a huge study, and it identified that whether you're talking about men or women, any socioeconomic group that you want to talk about, everyone is seeing the same effect, that our lives are getting shorter. And it's not just related to COVID. I hear that a lot. And yes, COVID was a significant factor in this. But as you can see in our peer nations up here, there was a fall off, but we're starting to recover. In the United States, it was much, much steeper, and we're not recovering either. So something different is happening in America than other developed countries. If you look at how much effort we're putting into health and wellness, it's even worse. So this is comparing life expectancy to the amount of money put into health. Our peer nations are way up here, and the United States is falling off further, further, and further. We're trying, but we're failing. Our efforts going into the wrong places. So what's causing our life expectancy to be shorter? That should be something we're interested in knowing so that we can avoid it, right? So there's three main causes. There's drug and alcohol-related deaths. And we talk a lot about the drugs, and again, we should. Over 100,000 people died of drug overdoses last year, and the year before that, and probably next year. Over 100,000 people from drug overdoses. We don't talk a lot about the alcohol part. If you look at alcohol-related deaths, they're greater than all other drugs combined. So if you know anyone that's struggling with alcohol, help them get help, because you're going to save their life. And I admit people to inpatient recovery centers, and most of the people admitted there are dealing with alcohol-related issues. It's probably about 60%, and the other 40% are all the other drugs combined. So alcohol is a significant factor in this. We don't talk about it a lot, but it's serious, and we need to talk about it and not just make it socially acceptable to go out and, drink on the weekends because you had a long week. Well, some people get away with that and some people don't. And the people that don't die. The second is suicides. So we're dealing with deaths of despair. If you look at those two, it's really clear to see how toxic stress in someone's life could cause people to turn to drugs, cause people to turn to alcohol, cause people to escape through suicide. The third is cardiometabolic diseases. Now that might not be as obvious, but what we know through decades and decades of studies is that heart disease, stroke, cardiometabolic diseases, they're directly related to the amount of toxic stress that you have in your life. The more adverse childhood experiences a child has growing up, the more at risk they are of heart disease, stroke, and others. The more stress someone has in their life, the more at risk they are for heart attack and stroke. So all three of these leading causes of death in the United States can be directly related to toxic stress within our communities. If you look at different communities, life expectancy can be very different as well. In Scott County, where I practice, life expectancy is about 73 years. If you look at Hamilton County, it's almost 82. So in the same state, depending on whether you're born in Scott County or Hamilton County, you could have about a 10-year difference in your life expectancy, just based on where you're born and raised. Does anybody know the original definition of the American dream? That everyone has the same opportunity regardless of your circumstance at birth? So life, liberty, and the pursuit of happiness is what America stands for. Life depends on your circumstance at birth. So what happened in Scott County? That's why I'm here. That's why I wrote the book. Something significant happened in Scott County. And again, I consider what happened in Scott County one of the canaries in the coal mine that should be warning us of these toxic conditions so that we can pay attention to that. So what did happen? We have multiple overlapping issues that developed into a perfect storm. The opioid epidemic, obviously, the socioeconomic demographic harms, public policy, and then, of course, the HIV and hepatitis C. So where is Austin? Where is Scott County? Scott County's right off of I-65 between Indianapolis and Louisville, and then Austin is in the northern part of that. We have really all the bad social determinants of health. a low graduation rate, high unemployment, a lot of poverty, very little lifelong learning, so there's no colleges or anything like that in the area. Most of the jobs are factory-based. And again, a lot of our patients migrated out of Appalachia in search for better opportunity. And unfortunately, what they found was, a kind of concentrated area of poverty and generational toxic stress that's been handed down generation after generation. And as you know, with the opioid epidemic and how the pharmaceutical companies targeted people from Appalachia, directly targeted people from Appalachia, found primary care providers who were taking care of people either in Appalachia, who had migrated out of Appalachia, who were working factory jobs, who had a lot of pain, and convinced primary care doctors that addiction's rare. Addiction's rare. Much less than 1% was what was quoted in the 90s to doctors. Doctors were told this. There were educational programs, continuing medical education programs you could go to and be taught that if you prescribed opioids to your patients, less than 1% of them would become addicted. And we know this isn't true now, but we didn't then. And so this was propagated all across Appalachia, all across the Midwest and other parts of the country to the point where it ravaged communities. And in places like Indiana, we really didn't even have access to addiction services to refer these patients to. In Scott County, it's even worse. Public policy. Really, in Scott County, it was based on personal responsibility. You need to try harder to do harder again. If you're not doing well in your life, if you're experiencing bad outcomes in your health, it must be because you're not trying hard enough, not because you don't have the access to resources, the knowledge, the tools that you need to convert that effort into outcomes. It must just be that you're not trying hard enough. So there wasn't access to any harm reduction there at all. Testing for HIV, for example, was really non-existent. We had one public health nurse in the county, and they were stationed in the county seat of Scottsburg. It's about 6-7 miles away. It takes about 20-25 minutes to walk a mile. So just to walk there, my patients don't have cars. They bike or walk everywhere they go. One public health nurse for the entire county, 26,000 people. There wasn't any testing going on. There wasn't connection to care. A lot of that's changed now, but it wasn't there at the time in 2015. And this is the way people were living. If they had a place to stay, it was run down. Sometimes it didn't have even running water. Think about that. Maybe their electricity wasn't turned on. People would burn trash to stay warm during the winter. Those are the people that had shelter. I opened my practice there in 2004, and I was immediately overwhelmed by the amount of distress and stress that I saw in people's lives. People were coming in and describing existences that I really didn't understand still existed in the United States. Again, no running water, no electricity, burning trash. It shocked me. I had gone overseas. I'd been on mission trips to third world countries, but even there, I didn't see the same conditions that I saw right here in Indiana, and that troubled me. And I really didn't feel prepared for my medical education. I was taught how to take care of diseases in medical school, not how to deal with social, circumstances that were harming people. It's a complete different thing. People would come in and they would ask for Percocet, Xanax, and Soma, those three in combination. They asked for it so often, I kind of, nicknamed it the devil's triad. Patient after patient, I want Percocet, Xanax, and Soma. And I was like, no, we're not going to do that. Let's look at something else. Some patients, they were dealing with chronic pain and I was the only doctor in town, and they were on opioids, and so, there was an effort to try to help people get off of those. Samantha is one. She was in her late 20s, dealing with back pain. She had gone to a back surgeon, had back surgery. He was prescribing her pain pills, opioid pain pills. But it was, several counties over. It was a long distance for her. She knew I was new to her town, and I was her doctor now, and she asked if I could help her. And I said, sure, we could work together. You're young. There's no reason why with physical therapy and some effort we can't get you to where you're functioning in life without pain or with less pain, and we could get you off of these. Got her medical records, did a urine drug screen, checked with the pharmacy. Everything checked out. She was taking just what she was prescribed, the way that she was prescribed. So we started working together. I gave her this contract. It said, you're not going to sell your drugs, you're not going to take anything else, blah, blah, blah. She signed it. We went on. Referred her to physical therapy. She was doing great. Had a lot of hope for Samantha. She was showing up to her visits. She was passing her urine drug screens. She was doing her physical therapy. She was improving until one day did a drug screen and got that back, and it showed that she was taking other substances other than what I was prescribing her. Now, this is around 2004. At the time, I had just graduated and was taught that there's certain patients that are too difficult to deal with, that it would burden down your entire practice, and so the best thing to do in a circumstance when you're dealing with someone who's using other substances, like Samantha, would be to just dismiss her from your practice. In fact, I had been given this form letter by one of my preceptors on how to do this. And so I pulled up the form letter, I put Samantha's name in there, sent it off through the mail, went on seeing patients. At the time I didn't think I was the only doctor in town. Where else would she be getting medical care if I kicked her out of my office? I didn't think about that at the time. I was just doing what I was trained to do. But a couple days later, she came in with my letter, ripped it up, threw it at my receptionist's face, started yelling and screaming. Dr. Cooke cut me off. What am I supposed to do? Started tearing posters off the wall, knocking furniture over. It's a completely different person than the Samantha that I knew. We didn't know what else to do but to call the police, so they came and took her out to the police car. And I remember looking out my office window at this 20-something-year-old woman, back of a police car, head draped down, hair hanging in her face. And I remembered my Aunt Sally. That's the age I remember her best is late 20s, early 30s, how she would come to family reunions, and she'd be fun. I mean, she was a really funny, energetic, alive person. And then she would disappear for a little while. She'd get arrested, she'd go to a recovery center, she'd come out and be doing better, come to family reunions, disappear, come back, long sleeves, disheveled. We knew she was using again. Sometimes my parents wouldn't let her around us. And this was a cycle with my Aunt Sally. She'd show up for a while and then disappear and show up for a while and disappear until she stopped showing up at all. And I'm looking at Samantha and I'm thinking, what is there for Samantha? There's got to be something better. So I asked the police officer, what is there? What kind of help is there for people like Samantha? And he just shrugged and walked away. And I started, thinking about this because it really troubled me, and that connection between Samantha and my Aunt Sally kind of really triggered something inside of me to look into this more. And what I started realizing is going back into college, I started thinking about Maslow's hierarchy of needs. You familiar with this? And as I'm looking around the community, and again, we had hundreds of people coming in asking for drugs. And the police officer and others started describing how these hundreds of people would get arrested and released, arrested and released, arrested and released over and over again, but there was nothing connecting them to the resources to help. And looking at Maslow's hierarchy of needs, he said that if you look at someone's life and it doesn't appear like they're improving, that they're doing better, it's not because they're not trying hard enough. Try harder, do better. It might be that they're so focused on lower needs that all their effort is being put there instead of progressing in life. And so you have to, it's like a staircase. You have to climb the first stair to get to the second. So if your basic human needs aren't being met, food, water, shelter, you're going to be focused on that. For mothers, if your children's basic human needs aren't going met, you're going to focus on those. And I've seen women do desperate things just to take care of their children, to be safe, to have a sense of connectedness or belonging with other people. These things matter, and unless they're met, we don't progress in life. And Maslow said, if you look at someone, they don't appear to be improving, it's probably because a lower need's going unmet. The opposite's true. There's things called adverse childhood experiences. ACEs is what they're called sometimes. These are adverse events that occur in a child's life as they're growing up. It could be physical abuse, could be emotional abuse, could be losing access to a parent. There's a lot of categories. But as a child develops more and more of these adverse childhood experiences, or generational trauma is passed down to them, or they're born in social circumstances that don't allow them to feel safe, have their biological safety needs met, etc. What happens as they're growing up is there's neurodevelopmental disruption, and there's actual places in the brain that these adverse events target, the frontal lobe, the temporal lobe. These are areas where rational decision-making, planning ahead, emotional regulation, memory. So a kid that's raised in this has this neurodevelopmental disruption. It leads to risky behaviors. It leads to social issues. They don't do well in school. They're targeted as ADHD, maybe put on a stimulant. A stimulant is very similar to, a stimulant is mostly amphetamine, which is the same as meth, essentially, methamphetamine. So why would we be surprised that methamphetamine is so prevalent in our communities? And this leads to development of harms, accumulation of toxic stress leading to cardiometabolic diseases, drug and alcohol-related diseases, deaths of despair, HIV, and then it leads to early death. So, someone could either be climbing the ladder of success in life based on having their needs met, or falling further down and experiencing early death by not having their needs met. And this can actually be spread out to any disease you want to look at. The literature is really clear that, you can name something like cervical cancer that doesn't seem to be even related to toxic stress in someone's life. All right? But what we know is that cervical cancer was the leading cause of death among women in the 1800s. But now we have screening and preventative tools that will prevent any woman from dying of cervical cancer, as long as they have access to screening and preventative services. So why can't we get down to zero? If no woman should ever die of cervical cancer, what's keeping us from getting down to zero? There's some invisible force keeping us from getting down to zero. What is that? And if it's causing women to die young when they don't have to, that's a form of violence. It's not direct, visible violence, somebody taking a knife and stabbing someone. It's invisible, but it's still violent because a woman should live into her 80s, not die in her 40s. And sometimes that's actually built into the structure of our communities. Depending on what insurance you have, or if you have access to insurance, you may have access to certain tests and procedures that someone else doesn't, for example. Depending on where you live, you may have access to transportation to get to a doctor. Depending on where you live, you may or may not have a doctor to even go see, right? So the social conditions in which someone is born and raised will affect even something like cervical cancer. So it doesn't just apply to substance use disorder. It applies to really anything: diabetes, heart disease, cancers, cervical cancer. Because health, it's a visible thing. We can see it when somebody comes into the emergency department or into my clinic. We can run some tests and we can kind of get a good idea of what kind of health that person has, what they're at risk for, and all of that. But what we don't see are all these things that are underlying their health. How were they raised? What were their conditions growing up? Do they feel connected to community? Do they have access to transportation? Do they have a job, meaningful work, a livable wage, access to lifelong learning? We don't see these things, but they matter. They're under the surface. Again, they matter, even though we don't see them, because the people in our community are usually actually trying really hard. We don't see where their effort is going into, though. Their effort might be going in to things that we don't see, because they're pushing their health risk up against a gradient. Some gradients are pretty low, because people have transportation, a doctor, insurance, all of those things. But other people don't, and we don't see that. And we don't see that their gradient that they're pushing their health risks up against is really steep, because they don't have transportation. They just have a high school education, or they maybe dropped out, and they don't have a job, they don't have shelter, they don't have a community, they don't have a family, maybe they just feel alone. And we don't see that, do we? But it matters, because they might be trying really hard, and to tell them to just try harder and you'll do better is not going to do a dang thing for that person, unless we get underneath of the surface and address the things that are causing the gradient to be steep in the first place. If we lower the gradient, then their effort starts paying off. And so to me, in order for someone to be responsible for their health, a few things have to happen. One, they have to have the capacity to act. In the legal system, if someone doesn't have the capacity to act, they're not held responsible for the crime, right? They have to have access to the resources to have health. And it all kind of fits together, and it gets complicated, but to me there's three main overlapping things that, if we can remember, to me this is what really matters on whether or not an individual or their community has responsibility for the health outcomes there. The first one, again, going back to Maslow's hierarchy of needs and all of that, is for someone's basic human and safety needs to be met. So unless someone's basic human and safety needs are met, I don't see how they can be held responsible for their health outcomes. If they don't have food, water, shelter, how can they be responsible for taking care of their diabetes, hypertension screenings? We have to look at their social environment in which they're born into. Sometimes the culture of their family, in the South, for example, for HIV, just a random topic, it's HIV, it's in the book. In the South, a lot of people are told that they shouldn't get treated for their HIV because they should just pray the HIV away. This is a thing. If you just pray hard enough, your HIV will go away. You don't have to take your medicine and people die. So we have to look at the social environment in which someone is raised. If they're born in one of these communities that have a low life expectancy, there's things going on in that community, that social environment that's causing harm. So we need to take into consideration their social environment. And then the last is just having access to healthy choices. I want you to remember this. It seems really obvious, but I want you to remember this, that people can only make choices from options available to them. People can only make choices from options available to them. So if someone doesn't have access to a doctor, to transportation, to insurance, to their medicine, you name it. Some communities are food deserts. They don't have healthy vegetables, fruits in their communities, and yet we try to hold them responsible for eating healthy. People can only make choices from options available to them. So whose responsibility is it to give people the option to make healthy choices? With my kids, it's mine, right? It's not their responsibility to find healthy choices to make choices from. It's my responsibility to provide that to them. And I'd say the kids growing up in our communities are no different. Every child in our community, I believe, has the right to have access to healthy choices, but not everyone does. If that child's basic human and safety needs are met, we're addressing their social circumstances, and they have access to healthy choices, then by all means, that kid, when they're 18, 20, they should be responsible for their health outcomes. If they don't have access to these things, how can we hold them responsible and say, you just need to try harder to do better? Maybe we need to try harder so that they can do better. I moonlight in the emergency department sometimes, both for thrills, but also it helps pay the bills, honestly. Having your own practice in a rural area, treating patients who are predominantly living in poverty can be difficult sometimes. So I would moonlight to pay the bills. I also liked it, to be honest. This case, my wife told me not to linger on this slide because it's difficult to look at, but she said this one's hard too, so I don't know what to do. So I want to tell you about this young lady who was brought in by her sister. Her sister came into the emergency department kind of out of control, yelling, screaming, my sister's dying, help me, please. And so we went out and pulled her sister out of the car, very young, frail, probably in her 20s, very thin, track marks up and down her arms. We put her in the emergency department exam room and started working on her. Listened to her heart. It was very rapid. Pulse was very thready. It was pretty clear to me, based on the track marks and how she looked and how her heart sounded and her blood pressure being low, she was probably septic, probably from injecting with a syringe that was not sterile, probably had bacteria in it. She injected bacteria, unintentionally directly into a vein, probably went to the heart, caused an infection throughout her body, developing into sepsis. And unless we got fluids rapidly infused into her and antibiotics, she would probably die. So I told the nurse, start a bolus, start broad spectrum antibiotics as I'm continuing to examine her, make sure she doesn't have any injuries, blah, blah, blah. They said, we can't get an IV. I said, why? She used up all of her veins, doc. So in an emergency situation, when you can't get an IV access, sometimes we do what's called an interosseous infusion. So her sister's still here in the corner. I'm trying to save her sister's life, and the only way I can get fluids and IV antibiotics into her is to basically drill a needle into her bone. Now, the bone has bone marrow. It's where the bone cells are produced, and they go into the bloodstream. It's direct access into the bloodstream. So I knew if I could get this needle in there, we could do the fluids and the antibiotics and everything. We could hopefully save her life. Now, Being young and naive and not thinking, I said out loud with her sister standing right here, we got that new IO device the other day. I've been looking forward to using it. Let's break that thing out. So they brought it to me. I opened it up, put the needle on it. It's like a drill that you would use at the house, right? And so I found my landmark right below the knee, pushed the needle through, pulled the trigger, vroom, and she screams. And the sister gasps. We hook it up, start giving her the fluids. I move around to the side of the, because you can imagine, bone is exquisitely tender. Anybody have a broken bone before? No one? Okay, a few. Bone is very, very sensitive. So, I mean, it hurts. That's why we only do it in emergency situations. And we only leave it in as long as we need to. So knowing that, I was going to try to get what's called a central line. Now, you have a big vein that goes under the collarbone. So I move around to the side of the bed, and I start pushing on her right collarbone, looking for my landmarks. And now I have a syringe in my hand about the size of a cooking thermometer. And sister's standing there, and I'm getting ready to put this in, and the sister says, "Stop, what are you doing? You're hurting her." I turned to her with this big syringe in my hand. What? She said, "You're not treating her like a person. I heard you say you were looking forward to using that thing on her." And she was right. I had said that, and I was being rather rough with this whole situation. In our training, we use mannequins, right? And we practice these things over and over and over and over again so that when we're in this situation and we're dealing with somebody that's dying, we don't go, "Oh my goodness, she's dying, what do I do?" I say, "Give me the IO device, put it in, get the line hooked up, start the infusion." You already have everything kind of lined up. You've done it enough times, it's just second nature. But what's easy to forget is this is a human being, and that's her sister. And when she said that, "That's my sister," something sparked in my brain, and I remember how my mom was called to the hospital. She was put into this room, and a doctor came in and sat down next to her and said, "I'm sorry, we did everything we could, but your sister's dead." And we knew what "we did everything we could" meant. We knew that they'd stripped her naked so that they could get access to her body to do procedures to make sure that there weren't any injuries. They'd done chest compressions that, if done right, probably cracked ribs. They'd shoved a tube down her throat to help her breathe. And my mom was sitting in one hospital room alone. My Aunt Sally was laying naked, alone, and dead in another. And here's this woman pleading for her sister's life. And that, I don't know, it just struck me. This person isn't a mannequin. They're not a drug addict. They're not some homeless person, whatever label we want to use. This is a cherished human being, someone's sister. And it just really struck me. It changed me. And I said, "You're right. Let me explain what I'm doing." And I started telling her why we were doing things, being mindful of what I was saying out loud and how I was saying it. And that changed that whole dynamic in the room. And the sister started being interested and understood why we were doing what we were doing to her sister. We got the central line in. We got that established, was able to stop the IO device, got her stabilized and moved to a larger hospital, and hopefully she did well. But, that struck me that, the people that we come in contact every day, it's easy to just write them off. It's really easy to treat them gruffly. We don't know them. We don't know what's happened to them, what their life story is. And someone loves them desperately. And maybe they don't know what to do or how to help them. But They are cherished by someone. That's my Aunt Sally in the middle. And you can see how much fun she was, how alive she was until she wasn't. That's my mom. So what does it take for someone to grow up and be healthy and well? And there's a lot of things that go into it, but the Surgeon General a few years ago boiled this down in a really nice report called Community Health and Economic Prosperity. And he linked what it takes for a community to not just be healthy, but to be prosperous as well. And it makes sense if you think about it. In order for a community to have economic prosperity, the people living in the community need to be healthy, right? And there's over 30 years of research that are poured into this report. And there are 7 vital community factors, sometimes called social determinants of health, that if a community has these 7 things, then that community will likely experience health, the people living in it, health, but also prosperity as well, both health and prosperity. The 7 factors are right here. It shouldn't come to a surprise at this point in my talk unless I've done a really bad job. Basic human and safety needs. Again, in order to have health and prosperity, wellness, we need to have our basic human and safety needs met. Lifelong learning, livable wage, humane housing, reliable transportation, a thriving natural world, a place where it's safe to go outside, to exercise, to experience community. And the thing that holds it all together is a sense of belonging and civic muscle. Because if a child grows up in a world where they don't feel like they belong, that's a dark and dangerous world where they're not going to feel safe, and they're probably not going to do well. But if a child grows up in a community where they feel like they belong and people care about them, they're willing to take risks and to do more and to ask for help when they need it. The civic muscle part's really important. That means that if I ask for help, I'm going to expect to receive it. That the people in my community care about me enough that when I say I need help, there's going to be a response to that effort to get help. So if you look at these 7 vital community factors, either you have a community of opportunity or a low opportunity community. And you can see that with life expectancy. And again, I like to bring it back to the children because, I think it's easier for people to care about children than, the homeless person that we might pass on the street. But that homeless person that we passed on the street was a child, and something happened that led there. So let's talk about the kids. 1 in every 25 American kids are not going to live to be 40. So when you leave and you see the kids in the community, 1 in 25 of them are going to die before they're 40. That should really not sit well, but it's the truth. And our peer nations don't experience this. If you look at this 10-mile radius near Washington, D.C., depending on where a kid is born and raised, they may have 33 years difference in the amount of life that they can expect to enjoy. 33 years difference just in a 10-mile radius. Again, life expectancy shouldn't depend on the social circumstances of your birth. Let me try that again. Life expectancy shouldn't depend on someone's social circumstances at birth. Yet, in a 10-mile radius, 33 years difference. Because trying harder isn't enough. I should start bringing this with me. I have this broken off piece of lawnmower cord on my desk at home. I keep it on my desk to remind me that just trying harder isn't going to solve the problem. I'm stubborn, and I don't give up I'm very tenacious. I learned that from my mom. She dropped out at 16 years old. She's a doctor. I didn't tell you that. She dropped out of high school at 16 years old, and she's a physician. She's tenacious. She's stubborn. She will not give up. I will not give up. I pulled this lawnmower cord until it broke. That lawnmower did not start. And then it became a lot harder to start it because there was no cord. I had to take the dang thing in, and, I caused more trouble for myself by not just stopping, looking under the hood, and finding out what the problem was. We can do that. Samantha came back to the emergency department, it's probably about 8 years after I dismissed her from my office. She came in with abdominal pain, and I walked into the room, and I sat down, and she recognized me, I recognized her, and it was awkward. But we get past awkward when people need help. And, I said, Samantha, I'm here to help you. I'll do everything I can. What's going on? She started telling me how she was experiencing this abdominal pain, and it had been getting worse over the last few months, and over the last few days it had become unbearable, and she came in. And I said, we'll figure this out. Went out, wrote for some medicine to help her feel better, ordered some labs, some studies, started seeing other patients. At some point, the guy that was with her came out and handed me this letter and said that Samantha had been carrying the letter around with her for a few months. It was addressed to me, Dr. William Cooke, had my address on it. And he said she was just afraid to send it to you, but she's been carrying it around. I think you should read it. So I went back to my desk, opened it up, and it described how she was raised in a home where there was a lot of alcohol use, a lot of poverty. She never felt like she belonged, never felt safe. Around 13 years old, she went to a dentist, and she was prescribed an opioid pain medicine. 13 years old. She took that, and it didn't just help with her physical pain. She said it changed something inside of her to allow her to feel safe for the first time in her life. Imagine that. A 13-year-old takes a pill, and for the first time in her life, she feels okay. What do you think she's going to do? She could read. She would go into her parents and neighbors and relatives' medicine cabinets and find something that was about the same name and start taking that, because being safe is a very powerful reinforcer. We have a center in our brain. It's a reward center in our brain that identifies people, places, and things where we feel safe, to encourage us to return to those people, places, and things. That's why we have such a strong bond with our mom, mostly, or where we were raised, or these places where nostalgia sparks. Those are probably places where we felt safe at some point in our life, and that reward center is very powerful. Somebody that's never felt safe in her life, never had that release, and the first time she does is when it was a pill. It's a very powerful reinforcer to return to that over and over again. And at 13, she doesn't know what that is. Of course, she didn't say all this in the letter, but I know this, so I'm reading it. And she continues using through high school, and then at some point she realizes what she's taking, and she doesn't like it. I don't want to be an addict. So I thought you could help me, and I messed up, and you found out and kicked me out. I don't blame you, but I need help. I don't want pain pills. I just want help. Will you take me back to help me? Now, at this point, I had stopped discharging patients from my office. Instead, I would bring them in and have a conversation, figure out what was going on, hear their story, connect them to resources. So people like Samantha that I had already done that to, I felt really guilty for. I've been carrying around this burden with me on how I had, discharged Samantha, and here she is asking if she could come back. I'm like, yes, absolutely. Nothing's going to keep me from going back in there and saying, Samantha, yes, let's work together. And I pulled up her CT results, and it showed metastatic cervical cancer. So metastatic cervical cancer is a cancer that no woman should ever die of if they have access to screening and preventative services. And I was the doctor in her community to provide her those screening and preventative services to her, and I told her she couldn't come to me. And because she didn't have access to screening and preventative services, not only did she develop cervical cancer, it's now metastatic. And instead of going into the room and saying, of course I'll help you, I have to go into the room and tell her that she has metastatic cervical cancer. And, she probably only has a few months, maybe a year to live. So, the things we do matter. And limiting access to people matters. Again, people can only make choices from options available to them. If Samantha doesn't have the option to get cervical cancer screening and prevention, how the hell is she supposed to? And whose fault is it? So I brought her back into my practice, and we worked together over the next couple of months, but it didn't keep her from dying in her late 30s like my Aunt Sally did. And she left, 2 kids just like my Aunt Sally did. So going back to the opioid outbreak and HIV in Scott County, there were certain landmarks along the way that were missed. In 2011, what we saw in our community was there was an increase in soft tissue infection, endocarditis, sepsis. This is indication that there's injection drug use in the community. And we saw this. There was a change in the way that the opioid, was manufactured. They changed it. In fact, the manufacturer had done studies to show that it actually increased drug use, but they suppressed those studies. That change resulted in an increased drug use, IV drug use in our community. People started injecting because they used to crush it and snort it. They couldn't do that anymore. It would cause it to turn into a gel. So they could melt it and draw it up into a syringe, inject it into their vein to get the same results. You may or may not be aware of opioid withdrawal and how awful that feels. Imagine the very worst case of the flu that you've ever had, and then multiply it by 1,000. And that's opioid withdrawal. When we feel that bad, we would do anything to feel better. We take NyQuil and, all these things, these remedies, right? And we hole up in a room and, a few days later we feel better, but they don't. This lingers for a week, 10 days sometimes. They'll do anything. A lot of my patients will say that they didn't even inject themselves the first time. They didn't want to do that, but a friend felt so bad for them that they injected for them. And then once that first injection was given, then they started injecting. And since, syringe distribution was illegal at the time, people didn't have sterile syringes to inject with. And so they would either inject with the same syringe over and over and over again, or they would share syringes with other people. And when you inject with a syringe that's not sterile, you're injecting bacteria into the bloodstream. If you're sharing syringes, you're injecting whatever virus or bacteria that person has into your bloodstream. So we started seeing an increase in hepatitis C cases in the community. Hepatitis C is a harbinger of HIV. This made national news This is an article from Reuters. You can't see this, but it says Austin, Indiana, right there. National news said Austin, Indiana needs help. This is 4 years before the outbreak. The Indiana Department of Health identified Scott County as one of the places in Indiana that had this hepatitis C epidemic brewing. And again, hepatitis C is spread the same way as HIV. It's a harbinger of HIV. If there's a lot of hepatitis C in the community, HIV is already there or it's coming very soon. Again, there was no testing in the community. We had one public health nurse. And so HIV actually entered into the community around 2011, and we didn't pick up the first case until right at the end of 2014, beginning of 2015. And so people had been contracting HIV for years leading up to that point. If there had just been testing in the community, it would have prevented the whole HIV outbreak, and I'd probably be standing here talking about something else if I was standing here talking at all. That would have never happened in the first place, but it did. And once we found out that people in large numbers were contracting HIV in the community, multiple things happened very quickly. Governor Pence issued the emergency order to unlock resources that we would need. I vowed that no one would have to travel long distances to get care for substance use disorder, HIV, or hepatitis C. So my primary care clinic in Austin, I vowed that we would take care of anyone that walked in the door, and we made sure that we had the resources to take care of HIV. So we started treating HIV right there in the community. And then the health department started a syringe service program so that people had sterile syringes so that they didn't inject over and over again and develop soft tissue infection, sepsis, and die, or share and spread HIV and hepatitis C more. And between all of these, we quickly leveled off. And between July of 2015 and December of 2015, we didn't have a single new case. Treatment is that effective. Harm reduction is that effective. We went from 180 cases to none almost immediately. But this was a significant outbreak. It represented, it increased, you can see here, it represented a third of all the new HIV cases in Indiana. It represented a third of all the new, this is a town of 4,300 people. It increased the incidence of HIV in Indiana by 20%. It affected the entire state. Predominantly people living on public assistance, Medicaid. Treatment's not cheap. 20% increase in the number of people that were providing medications for office visits, labs. These things matter to all of us. Health and prosperity, again, they're related. The people contracting HIV, you can't see this slide, predominantly young people, split pretty evenly between men and women. The main mode of transmission was a combination of injection drug use and sex. This was a new infection. It had only been in the community for a few years. We know this because there's CD4 counts, which is the cell in the blood that's targeted, was still preserved. So only a few people had developed AIDS at this point, and most people had a co-infection of hepatitis C. And what we were told is that these are people who have made their choices in life. And even if we found them, they're living off the grid, predominantly young people who are mostly healthy, who are injecting drugs. They don't want to be found out, so they don't go to clinics and hospitals and announce, hey, I'm injecting drugs. They're living off the grid for the most part. So we had to go find them, get out into the community. I would send a couple teams out with water and food just to talk to people and allow them to feel safe accessing us to do testing and then hopefully connect to care. But we were told even if we could find them, they wouldn't be willing to take their HIV and hepatitis C medicines. These are drug users. They're homeless people, sex workers. They make bad choices in life. They're not going to make a good choice. But again, people could only make choices from options available to them. So why not make the option available to them and see what happens? So we did. We developed what is known as a recovery community organization of care. This is evidence-based. You can research this. SAMHSA funds this. Any community can do this. It's basically developing across all sectors in the community, whether it's education, government, public health, private doctors, hospitals. Everyone comes together, sheriff department. We had a meeting up in a church in Austin, and we had the sheriff sitting next to a couple people who were either in recovery or still using drugs, working on the problem together. They have a worksheet, and they're working together. And by inviting people who use drugs and asking them the questions of how we can help, not telling them how we can help, and then getting buy-in from the entire community, we developed this ROSC, Recovery-Oriented System of Care, so that anyone at any time, anywhere, could access help. We made it okay to say, I'm not okay. Because unless you feel safe saying I'm not okay, you're not going to say you're struggling. If you know that you're going to go somewhere and say, I inject drugs, you're going to get kicked out or police called on you, you're not going to say that. But if you go somewhere and say, I inject drugs, I need help, and you know they're going to help, something's different about that. And this developed into a recovery community organization that now provides recovery-oriented care to about 8 counties in southern Indiana. This developed out of the 2015 outbreak. It's people who were using drugs just a few years ago who've now received their recovery certification to provide care to 8 counties out of this tragedy. The community can come together and do this. It requires a multi-pronged approach across sectors, everyone working together. You can have structural interventions deliberately looked at in ways that we can reduce discrimination and inequity and figure out ways to enact better laws to protect people and to give them the sense of safety to access health in the first place. Biomedical, just increasing access to care, whether it's medication-assisted treatment or harm reduction. Screening. Screening doesn't have to just be in clinics. It can be in schools. We do screenings for ACEs in schools now. And those kids that are identified are connected to resources that we know can benefit them. Dialectical behavior therapy, for example, can protect someone with a high ACE scores from these adverse effects that happen later in life. Behavioral through education, therapy, peer support groups. When all this came together, a beautiful thing happened. We saw the number of people contracting HIV plummet. We saw the people entering into recovery. You can't see this, but there's a graph here. It's invisible. It just climbs higher and higher. This is people entering into recovery. So people contracting HIV, people entering into recovery. This is the number of syringes being distributed. Of course, it was 0 in the beginning. The syringe program opened, it climbed, leveled off, and started to decline because there were fewer people needing syringes. We were told people wouldn't take their HIV medicine. The national average at the time was about half of the people living with HIV were taking their medicine. In Austin, it was 80%. People were willing to take responsibility for their own health if given the option. People can only make choices from options available to them. We gave them the option. We allowed them to feel safe accessing care, and they did. Because people are willing to take responsibility for their own health. Not only that, once the syringe service program opened, safe disposal of syringes, 18% before it opened. 18%. Where on earth were they supposed to dispose of their syringes before the syringe service program opened? You can only make choices from options available. I'm sorry for repeating this over and over again, but it's true. If you have a syringe and you have no choice to dispose of that safely, how can you? After it opened, 86% of people were disposing of their syringes safely because they had the option to do so. Not only that, if people were living with HIV That went up to 98%. Almost every single person living with HIV who were still injecting disposed of their syringe safely. They weren't just willing to take their HIV medicine and take care of their own health. They were willing to take responsibility for the health of their community, if given the option to do so. Indiana, unfortunately, leads the nation in hepatitis C cases, and in every county that does not have a syringe service program, that's getting worse. Syringe service programs prevent the spread of hepatitis C, which is a devastating infectious disease. It's the leading cause of death from an infectious disease in the world. It's a terrible death if you've ever seen anyone die from hepatitis C. It's a terrible death. And it doesn't have to happen. It's completely preventable, and it's treatable now. And in Scott County, we decreased the incidence of hepatitis C by over 76% and the HIV by over 95% by treating it and preventing it through harm reduction, having the syringe service program. In 2020, we only had one new case of HIV. We have the highest number of people living with HIV who inject drugs in the state. Yet, in 2020, we only had one new case. In 2021, we only had one new case. It's a success story, right? The commissioners heard the success story. The commissioners said, you all solved the problem, so we're going to close the syringe service program. We had people in recovery go to the commissioners' meeting with us. And we told the commissioners that people take responsibility for their health by going to the syringe service program and asking for help. And out of that, we've developed this recovery organization that's providing amazing services back to the community. And more people are getting help because of this. People are making a healthy choice because they have the option to make the healthy choice. They're taking responsibility. Person after person stood up and told the same story, how they went there for help and they got help and now they're giving back. And the commissioners were really, really happy to hear this. You know, gave them big thumbs up, told them that they would do everything they could to help their recovery organization. But they're going to close the program, the syringe program, because people need to take responsibility for their own health. That was the reason they gave. And after they closed it, the first 6 months, we saw 4 new cases of HIV in that first 6 months. And then testing went from over 1,000 tests a year to under 100. So we don't even know. We don't even know how many people are contracting HIV now. But we do have people accessing care for new HIV infections every few months at this point. It's estimated that we're going to see a dramatic increase. I don't think it's going to be quite as devastating as it was because there's a lot more public knowledge of how HIV spread and not spread. There's more access to recovery services and help and HIV treatments and those sorts of things. But we are seeing a rise in HIV cases, and it doesn't have to be. In my book, I say that healthcare disasters don't just happen; they develop right before our eyes, and we either don't see it or refuse to see it until it's too late. We lived this story once. I wrote a whole book about it, and now we're doing it again. It doesn't have to be. Healthcare disasters don't have to occur. There are things we can do to stop it in the beginning by connecting with people and giving them access to care. It's not wrong to give someone access to care. We don't have to put all the burden on someone who doesn't have access to find it. That doesn't even make sense. So until we get to the upstream issues, how people live, where they're born, what social circumstances they're born into, are their basic human and safety needs met? Do they have access to healthy choices? That's where we can prevent this decline in life expectancy. one of the things I learned in medical school was that there's really no place on earth better at keeping sick people alive than in America. We do a really good job of keeping sick people alive. If you're sick, this is the place to be, because we're going to do a good job treating that. But we don't do a good job of growing healthy people in the first place. Again, what we want is not just a longer life expectancy, but also a longer health, right? We don't want 20 years of disease before we die. In order to do that, we have to invest in our communities upstream and not just respond to the diseases after they occur. To me, healthcare isn't what happens in hospitals and clinics. Healthcare is what's happening in the community where people are born, raised, and live. I'm only responding to what's already happened to someone when they come to me. Again, I was trained to take care of diseases, right? But over time, I've trained myself through research, and I think we're doing a better job of training the young doctors that healthcare is actually those social determinants, those 7 vital community factors. And that's where we really need to shift our investment. I showed you the slide of how much money we're putting into healthcare and how much worse we're doing. If we shift that funding from disease-oriented care to person-centered care by investing in those 7 vital community factors, we're going to eliminate not only a lot of the diseases that we see in our clinics, but also expand life expectancy and the health that someone can expect to maintain until the end. And this is the end. So these are some public policy statements. They say a lot of the things that I've said here, but you're welcome to look into some of these. And I just want to leave you with the fact that there's always hope. There's always hope. There's toxic conditions that are harming people, but there's something we can do about it. We can come together as a community to make sure that every child born in our community has access and resources and choices that they need to be healthy and prosperous. A lot of people to think about and thank. I'll try to list them here on the slide. I encourage you to read my book if you haven't. And yeah, that is it. Okay.
Let's thank Dr. Cooke. Isn't that amazing? And like you said, if you haven't read his book, I really encourage you to, and he did bring a few books. And one last thing before you depart, you can have time to ask him some questions, and I also want to share a brief survey that you'll know about before you leave the room. If I can pull it up. Just give me a second. And while I'm doing that, there'll be a survey up here. I'd like you to take that survey to let us know how we're doing with programming so we can continue to offer these programs to you. And while I'm doing that, do you have questions for Dr. Cooke? And I might ask him to repeat the question so we get it on the mic.
Yeah, feel free to shout it out, or there's a mic over here that you're welcome to use as well.
I've been looking forward to this since I first heard about this several months ago. I read your book, and I've bought other copies for friends of mine who are incarcerated. Every one of these Q&As has at least one guy who, instead of asking a question, makes a statement, and I'm going to help get that out of the way. So here in Allen County, we've got a syringe service program, and the way I understand it, every 2 years, our 3 commissioners vote on whether to continue it. It survived the last vote 2-1, which is a narrow margin. So do whatever you feel is right in terms of writing polite letters to our commissioners. And I do have a question, though. Has anyone been able to track what has gone on with overdose fatalities since the SSP closed?
That's a great comment and question. The first comment was that there's 3 commissioners that decide the fate of the syringe service program in Allen County. That's very similar to Scott County. We have 3 commissioners as well. It comes up every 2 years for vote. The first 4 years it passed, and then there was a new election, and instead of waiting 2 years, one of the seats were overturned, and it went from 2-1 for to 2-1 against, and they raised the vote within a year of it passing for 2 additional years, and they were able to close it immediately. So it does matter who gets elected, because it just takes, if you have 2-1 right now, it just takes one of those seats being overturned, and the program will close. What we've seen as far as overdose deaths, we've seen a decrease in fatalities. Overdoses themselves still tend to be an issue, but most people are surviving them now because of the Narcan distribution. Go ahead. Actually, it's reasonable to draw the conclusion that since the syringe service program closed, there's less Narcan in the community. But a lot of organizations have done a really good job of getting Narcan into the community. There's multiple churches, the hospital, who have Narcan boxes where you can just walk up and get Narcan. Most of the doctors prescribe Narcan. The pharmacies dispense it. So we still actually do have access to Narcan in the community. Testing for HIV, distribution of sterile syringes, those are 2 things we definitely have had a decline in. But the Narcan distribution actually is still pretty strong, thank goodness, because it is saving people's lives. I consider Narcan similar to an AED device. You see that sign somewhere in the library. If someone passed out and their heart was in a rhythm that was shockable, we can hook that up, shock them, and bring them back to life. Or the Heimlich maneuver, or CPR, bystander CPR. It saves lives. You know, it's something that we all should have access to, and if somebody overdoses, we can literally save their life and give them access to another chance to hopefully enter into recovery and do better. Yes?
I guess you're with the National Library of Medicine. I guess one of my relatives is there, but he's deceased now. But anyway, it's my understanding that the big thing now at NIH is transitional sciences and medicine. Do you have any war stories about how 2 institutes have ganged up, so to speak, maybe to attack a disease or something?
Could you say that one more time? I'm so sorry.
Transitional sciences or medicine, where 2 institutes maybe have ganged up to attack a disease.
So I'm in the clinical realm of things. I'm not in the research realm of things. So I'm really based in very much in a community, not the NIH. I'm not with the Library of Medicine at all. So I'm a clinical physician that's practicing in a community, not doing any research or anything like that.
Okay, thank you.
Yeah, sorry. Okay, thank you.
Thank you very much for coming to Fort Wayne for the first time.
Of course.
We always like to have visitors. I'm sure you, do the commissioners that have voted no have any access to the statistics you just gave us?
Yes.
And I suppose you regularly update that for them, hoping that will change.
In fact, Dr. Box, our health commissioner, was present and shared some of the statistics and the data that showed that there was a dramatic improvement and what would happen if it were to close. Dr. Adams, our previous health commissioner, and the Surgeon General of the United States actually came as well and spoke. And so, yeah, they definitely had access to it. They doubted the data. One of them actually said that he didn't even think that the HIV outbreak occurred.
Wow.
So data did nothing.
Right. Yeah. So do these commissioners do they correlate the Narcan assistance at all with needle prevention programs? I mean, do they understand the correlation between providing people these resources?
You've heard it said that maybe somebody shouldn't have more than 1 or 2 chances at resuscitation. Have you heard anybody say that? That's the stance. You know, that if you revive someone more than 3 times, they shouldn't be revived any longer. They're not thankful anyway, so why should we bother?
Well, thank you for all the care you do for your citizens
course.
of your region. It's
Yeah, of
very
course. Thank you.
gracious and wonderful of you. And you're right, it all happens at the voting box next Tuesday, doesn't it? Yes.
What else? Comments, questions? Yes.
So sometimes in a family that has those unmet needs, there is a child who survives it. And what do you find to be the reason behind that?
Yeah. So my mom's a good example of that. Even though she had dropped out of high school, she was still able to be successful. And the things that she describes to me is very anecdotal, but looking at the data kind of supports it. Mentors, people who poured into her. She describes this episode where she was working as a nurse's aide at a hospital. And a nurse's aide is the one that cleans the bedpans and such. And one of the nurses pulled her aside and said, I really think you should go back to nursing school, and started mentoring her and talking to her about what a nurse does and why it would be good for her to do that. She didn't even have a high school degree at that point, but that meant something to her, and she went back and got her high school. She actually went back to high school. She didn't just get her GED. She went back to high school and then graduated, went to nursing school, became a nurse, and then 10, 15 years after that went to medical school. But she describes mentors, really, the people that were willing to invest in her, encourage her, show her a different way of living. There's a book, Hillbilly Elegy, J.D. Vance. To me, when I read that book, the thing that struck me the most was his grandmother and how she would not let him fail. And he always knew that at the end of the day, he had one person who was going to defend him and encourage him and move him along. Not every kid has that. And I say it in the book, and research supports it. The thing that I think protects kids growing up in poverty the most is if they have one person they know will never give up on them. And not every kid has that. The kids that don't have that one person they can turn to are the ones that don't tend to succeed. It's the people who have that one person. Be that one person in a child's life. I encourage you to do that, whether it's at church or in your community, in your family. Invest in the children. Find that one kid and just convince them that no matter what, you're going to be there for them, and then be there for them. And when they ask for help, provide it. There's few opportunities we have in life to rise to the occasion to save someone's life. It's when someone's hurting the most that we have that opportunity. And if we fail that moment, that may be the end for them. So that's our opportunity to respond when somebody asks for help or to, share their heart with you. It's easy to look for the door. I get it. You ask somebody how they're doing, and instead of saying, I'm doing great, they start telling you. And then you're like, oh my goodness, that's not what I meant, right? But maybe they need that ear, just that sympathetic ear. And I know we're all busy, but it's worth just taking the time to show them that we care. What else? I got a story if you don't have anything. I don't want to keep you too long. Yes. it's
Mention anything about that throughout your thing?
yeah, methadone's complicated. It's federally regulated. It's only available at federally regulated clinics, and there's a moratorium in Indiana on new methadone clinics. So there's just a few in the state. Yeah, great. So, great. I think it's a fantastic resource that's always there for somebody that they can go and get help anytime, regardless of anything.
Do you think it would help with curbing opioid epidemic?
So let me just, so methadone, so there's several medication-assisted treatments for opioid use disorder. There's methadone, Suboxone or buprenorphine, and naltrexone, an injectable form of Vivitrol. They do different things. And methadone is the most regulated, it's the most restricted, but anybody can get into the methadone clinic and get daily dosing. And I think it's a great thing for our communities to have access to. I love the fact that Suboxone's there, where a patient can go to their primary care provider that they're already seeing for everything else, and it's not this separate thing that they have to go to. I think it's great that it's there, and it serves a wonderful purpose. But imagine if there was a diabetes clinic and a CHF clinic and a hypertension clinic and a primary care clinic, and the person had to go to all of these different places to receive their care. It would be really complicated for them, right? But if they could get all the care they need in one place with their primary care provider that also has the resources they need to do well, they tend to do better. It saves lives, and that's what we want to do first and foremost. The second is we want them to be healthy and prosperous. And so whether that's in a methadone clinic or in a primary care's office, if it works for them, it works for them. And to me, the biggest thing for a community dealing with a high incidence of substance use in the community are the behaviors that we see that kind of stem from that, whether it's petty theft or people not taking care of their kids or maintaining their homes, that sort of thing. What medication-assisted treatment does is, first and foremost, it saves lives because it keeps them from overdosing. And second, it allows them to be functional in their life, to where they can go to a job every day, maintain their home, take care of their kids, and function. If people in our community are taking care of their homes, taking care of their kids, going to work every day, being a productive member of society, that's what we want. And they can get that through the methadone clinic. They can get through the Suboxone or their primary care provider. So I think there's a place for it, and it needs to be there. And each person that accesses care is an individual. And they may do better in a methadone clinic. They may do better at their primary care provider's clinic. They may do better doing Vivitrol, on a monthly basis through an injection. I think it's a very individualized thing, but it needs to be there, 100%. Yes.
I don't know if you have an answer, but we used to live in a small town in a different county, and especially when meth hit, and there were meth labs rampant, and I think our county was number 2 in the state. But the denial of the public was amazing to me. Not in our town. No, how could this happen? So how do you get through that? We don't live there anymore, so it's not my problem anymore. But I mean, how do you get through that denial that this is not happening here? So if we do something about it, that means we have to admit we have a problem.
Well, there's two sides of that. She in case you couldn't, she was asking about what do you do when people aren't even willing to admit that there is a problem in the community? They're not willing to see the people with substance use disorder, whether it's meth or opioid use, heroin, fentanyl. That's not happening here. So there's two parts of that. One, it's a refusal to even see the issue in the first place, but the other is to see it and say they just need to go away. If we do anything for it, it's going to encourage more, and people are going to come here. And so the not in my backyard, mentality is real. How do you get past that? I think it's just through interactions with people who, usually in recovery, that can provide some education, but really provide that human side to the issue. Somebody asked about data earlier. What I've seen move people is not data, it's actually the stories, the people when they get to know them and meet them. And that's hard to do because people aren't willing to get outside of their comfort zones, right? We don't feel comfortable around people that we don't feel comfortable around. And the only way to feel comfortable around the people that we don't feel comfortable around is to be around them. But to be around them, we have to be uncomfortable. So there's that dynamic. And so to allow someone in that position to feel safe in an uncomfortable situation, whether that's at their church or their civic organization or whatever that might be, we held a meeting for one of the state representatives in Southern Indiana, and it was about him. Come, we're going to promote you. This is an opportunity for you to get your message out, but we want you to hear some of the stories of people as well. So maybe at a church where somebody feels safe already, you can have a workshop or a panel of people in recovery to kind of talk about the issues, and they might hear it in that setting. They may not, but what I've found is it's through that connection with another human being that they will see it and respond with some sort of compassionate approach to help, because we all feel that we're compassionate people. I don't know very many people that don't claim to be a compassionate person. And if there's someone sitting across from you describing how, 2 years ago I was injecting meth and I lived behind the 7-Eleven, and now I'm working and taking care of my family, and I'm a recovery coach and giving back, that sometimes unlocks something in them that allows them to see that. And that's not the best answer, but that's the best answer I have. It's easier to put the blinders up. And we all do this. And I'm not blaming anyone. You walk down the street, you see somebody that's struggling, and you don't know how to help them. The easiest thing to do is to not see them and to keep walking, right? It's uncomfortable, and so when it's uncomfortable, the best way to not feel comfortable, the best way to get rid of that uncomfortable feeling is to not acknowledge it, to deny it. So I don't blame them because they don't know how to help. The ones that are at least willing to acknowledge that it's there. It's easier to say no and turn away. Families don't know how to help their own kids sometimes, and they'll send them away, right? You're not welcome in my house anymore. And I just want to maybe close with this. I've heard the story of the prodigal son used to, advocate for tough love. See, you gotta have tough love for somebody so that they hit rock bottom, because until they hit rock bottom, they're never going to seek help. And that's not what that story is saying at all, because it's not that the son got there and said, oh my goodness, I've hit rock bottom. I need to go back to where there was, food and water and stuff. It wasn't that. Do you remember what motivated him to go back home? He remembered his father's love. So the last thing we need to do is to completely close the door on someone. Someone always needs to know that when the worst day of their life happens and there's nowhere else that they can turn, they can remember your love. Because that might save their life literally. Literally. it gets frustrating because people don't know how to help someone, and I get that, and it's easy to say no and turn your back and deny it, but people also need to know that there's a place where they can go that they can be safe when they need to. He remembered his father's love for him, and the father didn't wait until he came and apologized or said, I'll never do that again, or made agreements. You know, he saw his son in the distance, and he ran to him, and he fell on him, and he hugged him, and he kissed him, and he brought him back into his home. And so always leave that door at least cracked. You know, let your kids, your friends, whoever, know that if nothing else in life is working and you don't have any way to escape, you don't have to escape that way. You can escape by just coming and being safe here, and I'll make sure you're cared for.
Production facilities provided by Access Fort Wayne. Learn more under the Explore tab at acpl.info.